Dr. Alolabi, what are you doing? Yeah. Hey, Dr. Alolabi.
Hey,
Can you tell me about shoulder arthritis?
yeah, sure. So shoulder arthritis is a condition that involves decreased cartilage or cartilage wear in the shoulder joint. Basically, once the cartilage wears, you start articulating bone on bone, and that's defined as arthritis. We typically diagnose arthritis based on both the clinical and the radiographic side. So clinically, you need someone who has both some symptoms from the arthritis, which essentially mean pain, decreased range of motion, sometimes clicking or what we call crepitus or crunching in the shoulder. And then radiographically, you want to see the joint space narrowing, which is basically what indicates the cartilage on the X-rays. And once you see that narrowing and getting bone on bone or close to bone on bone, that's how we diagnose shoulder arthritis. Typically, there's different type of shoulder arthritis, but the more common one is what we call primary shoulder arthritis. It means just kind of regular wear and tear, and that the body starts to fight itself from wearing the cartilage by forming a lot of these bone spurs.
How do you treat shoulder arthritis?
The radiographs are one thing, but we obviously treat patients, right? So the focus is always on the patient's symptoms. If they don't have any symptoms, then they typically get treated just with continued watching, some anti-inflammatories and activity modification, decreased lifting, pushing, pulling. If they start getting more symptomatic, then we start introducing other things such as injections. So those can be cortisone injections, hyaluronic injections, which are called almost like a gel injection, which technically lubricates the joint and decreases the inflammation. PRP injections, which are the plasma. Those are kind of some of the injections that have been described for shoulder arthritis. Once you've exhausted all non-operative treatments, then you would go on to shoulder replacement. So this is what a regular shoulder looks like. You have the ball on the arm side, and then you have the glenoid, or the socket, on the shoulder blade side. And it articulates like this, and it kind of rotates around and goes up and down. When the arthritis is the normal arthritis of the shoulder, which is called primary arthritis, meaning you just wore out the cartilage, then we typically would replace it with a regular replacement. This system is a system I typically use because of many features I think are advantageous in shoulder replacements. It's called the Enhanced Shoulder System by J&J Depuis Synthes. So basically you would have something like this. So that's creating the metal ball, and then you'd have on the socket side or the glenoid side, you'd have this plastic replacement on the socket side, and this is what would be articulating. And I like the system because it has some very interesting features. This glenoid component, or the socket side, is circular, so it really allows the metal humeral head to articulate well and constrains it a little bit so that it's not sliding, which is what we see with some other manufacturers or other implant systems, therefore decreasing some of the forces on the rotator cuff, potentially preventing tears down the road. It also has this excellent ring fixation. It has a ring on the backside of the implant, and that provides excellent fixation right on the glenoid. It has features where you can put this in an inlay fashion, meaning you ream some of the bone and push it all the way inside of the bone, or it can sit right on top of the bone on an onlay fashion. So it has this extreme versatility that is really advantageous for it. It has this trabecular metal on the post. So it allows what we call a hybrid fixation, meaning the bone will grow into this porous metal, but then also this ring fixation around the periphery gets usually fixed with cement. It's very good, very bone preserving. The lovely thing about it is it's a one-step reamer for the glenoid side. So typically when we're doing the glenoid side, you have 5 or 6 different reamers and drills that you have to use to prepare the glenoid. Whereas this is really, we just put a pin right inside of the glenoid here. You just take this one-step reamer, you ream, and you're done. And you're ready for putting in your implant. You just put a little bit of cement around, and the implant's ready to be inserted. It has such a versatility. One step, 2 trays for the nurses. You don't have to worry about multiple trays. The nurse is trying to find what instruments you're asking for.
Can you tell us about the reverse?
Yeah. So we talked about when the shoulder arthritis is just kind of what we call primary arthritis or regular arthritis, but a lot of the times we'll have things where the rotator cuff tendons aren't there, because patients have torn them or, wear and tear over time, they kind of degenerate. or when we have cases where there's a lot of bone loss, so the bone over time has eroded significantly. Those cases, we typically can't do a regular shoulder replacement. It just won't work. You know, the rotator cuff create this force couple, meaning the rotator cuff tendons center the humeral ball on the socket. And that's really necessary. Once the rotator cuff is not working, the ball can't center anymore, and it starts becoming sloppy and moving all over the place. And a regular shoulder replacement really won't work with that. So in those cases, we do something called a reverse shoulder replacement. And it's exactly what it sounds like. We're kind of really reversing things. It's almost like upside down. So this really smart French guy, came up with this idea of reversing things and putting the ball on the socket side and the socket on the ball side. So this is an example of the system I use. This is the enhanced system by Johnson & Johnson Dupuis Synthes. In this example, you can see we're putting this base plate, this metal piece on the glenoid side. The nice thing about this is it's all secured through screws. So it has this ring in the back, which again is the same idea of the ring on the anatomic side. So it's the same reamer that's utilized for both of them. And these have porous metal that really grow right into it. And then this is a modular component where you can put this inside of the bone and then put a screw in it, or it comes as a monoblock, one piece with the screw kind of built into it. And then you have this glenosphere. So this is the ball, the metal ball now, but now it's going on the glenoid side or the socket side. And this would basically get incorporated right inside there. And then you'll have the socket now on the humeral side, which is usually a plastic socket which articulates with it. The reason why it really works very well is this creates a fulcrum. It's almost like a hinge, like a door hinge, so that now with this fulcrum, bigger muscles, the deltoid muscle, the pectoralis muscle, some of the back rotator cuff muscles, if they're still present, have a much bigger lever arm and a much better force to allow the shoulder to move despite the lack of other rotator cuff tendons from being there. Because of the fact that it has all this porous metal and screws, it also allows you to correct a lot of the deformities. This is what I really love about this system. This is a great feature. It's called a kickstand screw. Again, this is an example of this base plate that goes right onto bone. And if you have a lot of deformity or bone loss usually on the back side or the superior side of the glenoid, you would basically go as far as you want down there. These rings really offer a lot of that support. And then you would add this kickstand that goes right into this hole and right onto the deformity. So it really acts as a kickstand. It prevents the implant from rocking or moving. It gives it incredible stability. What's great about the system is that this is all in situ. You're performing this on the go. I mean, we still prepare all our plans before surgery, but while you're in there, if you find, there's still a defect or you don't want to ream as much or things change, you can literally at any point decide to put in this kickstand screw. It has multiple sizes and it really acts as a great feature for correcting these deformities. And then again, you would add your glenosphere here. There's multiple sizes of these glenosphere, multiple both diameter and length, giving it more offset. When we started doing reverse replacements, the idea was to bring the humerus medial and lower. So the Grammont, which is the French person who came up with this surgery, his ideas were to bring in the humerus more medial and lower down, therefore giving the deltoid a better working length. However, over time, we've realized that we can actually lateralize the glenoid and still have this fulcrum effect working really well, which acts better for the rotator cuff, restoring the length of the rotator cuff by lateralization. So this system has a +4 lateral glenosphere, a +8 lateral glenosphere. So it gives you that versatility of both. If you want to medialize for that patient, you can. If you want to lateralize, you can. If you want a small glenosphere, a 33 glenosphere, you can. If you need someone who has a bigger stature or revision cases, you can go up to a 40 glenosphere. One other really cool feature about the system is their humeral preparation. So the nice thing about the humerus is it's the same preparation for any different type of implant. So you can put what we call here a stemless implant, so a very short stemless implant. It has the same preparation. Or if the bone is too soft, then you can switch to a short stem. Then there's the standard length stem, and then you have kind of a revision length stem. And they're all prepared by this same method, just a one-step reamer as well on the humeral side. This system was really built on bone preservation, both on the glenoid and the humeral side. So you can see this is kind of an example of the amount of bone that you take. It's very minimal bone that you're taking out. So it preserves all of this bone on the inside of the metaphysis of the humerus, so that you're getting that good fixation, metaphyseal bite and peripheral bite on the implant, and you're preserving that bone for future surgeries down the road.
How do people do after shoulder replacements?
Typically, patients do extremely well after shoulder replacements, both with an anatomic and a reverse. There's slight differences. With an anatomic, I usually tell my patients they should regain back 90 to 100% of their range of motion. They wake up immediately without the pain that they have. Anatomic shoulder replacements typically last for about 15 years, potentially longer. A lot of the times the downside is not the implant, whereas it's the rotator cuff over time starts to fail just from wear and tear, and then their performance or outcomes start to become a little worse. But we've seen patients with 30-year or anatomic total shoulder replacements that are still doing very well. With the reverse, we already know based on the data that the reverses are outlasting the anatomic shoulder replacements, so they actually last for longer. The one downside is that the range of motion is probably not as good until now. So they often lose a slight amount of forward elevation right at the top. They lose a little bit of external rotation kind of towards the extreme range of motion. And probably the most important one for patients is the loss of internal rotation. Most people can get to the back pocket, but not kind of higher up. Now there are some patients that still manage to get more motion, but on average, the average patient gets to about the back pocket for internal rotation.
I've heard you can be too young for a shoulder replacement. Is that true?
When we started performing these reverse shoulder replacements, the indication was that the patient had to be 70 years and above to do the shoulder replacements. And a lot of the surgeons earlier on started with that. However, as we've gotten more comfortable with them, I've done a reverse shoulder replacement on a 25-year-old for when there's no other solutions, or they failed an anatomic shoulder replacement. Rheumatoid patients tend to have really bad bone and really bad rotator cuff, and they often don't do very well with an anatomic shoulder replacement. So I don't think there is an age criteria. We just always have to be cautious about what's the next surgery. When if this patient 20 years down the road needs a revision, what are we going to be able to offer them? How are they going to fail? So those are just things that you need to consider. We typically like to see the patients being above 50, 55 years of age when we put a reverse shoulder replacement. Having said that, again, there's really no age limit. It just depends on what the indication is and whether the patient has any other options or not.
What is a shoulder replacement made out of?
Most shoulder replacements, so most of the stem is titanium, and then if you have a humeral metal ball or the glenosphere, that's usually made of cobalt chrome. The plastic portion is highly cross-linked polyethylene with vitamin E, essentially a type of plastic that is very resistant to wear, and the vitamin E helps that longevity of the implant. So it looks a little more kind of on the yellow side from the vitamin E.
What if I have a nickel allergy? Can I still have a shoulder replacement?
So the titanium is fine. The cobalt chrome is usually the issue with patients who have or who potentially have a nickel allergy, and there are nickel-free glenospheres and nickel-free humeral heads for those patients. However, there's really a lot of debate of whether nickel allergy is a contraindication. Most patients with nickel allergy can still get a regular shoulder replacement. The cells that create the allergies on the skin and not inside. But there are a minority of patients that may present with what we call a true metal allergy, and in those cases, we may have to choose a different implant for them.
If a patient has all this metal in them, can they go through airport security without beeping?
It seems like some machines pick up the beeping and some don't. I usually tell patients, if you do beep, just tell your officer that you've had a shoulder replacement. Worst case, they may want to see the incision, but really they don't ask anymore. It's so common. Almost 1 in 3 patients now have some form of a replacement, either knees, hips, or shoulders. So it's very common for that to happen, but they still, especially with the titanium implants, they don't tend to buzz through the airport.
Awesome. Thanks, Dr. Alolabi. Where can people find out more if they need to?
You can check out Mac Upper Extremity on Instagram. That's our fellowship upper extremity page. You can also check Scrubbed Out for more information.